Okay, let's talk about this really cool case of a patient who presented with thumb swelling and redness. This was a 21-year-old male with right thumb pain. He stated it was swollen and red and painful for several days. He did not have an injury. He had no systemic symptoms. There was nothing draining from his thumb. He worked as a laborer. He basically had no medical history and was not sure about his last tetanus shot. On exam, his vital signs were okay. His temperature was normal, heart rate normal, blood pressure, respiratory rate, and oxygen sat were all normal. His thumb was impressive. There was redness and swelling of the distal phalanx on the dorsal aspect. There was fluctuance and tenderness on palpation, especially around the nail bed on the radial side of the thumb, which somewhat limited the range of motion of the distal interphalangeal joint. The nail was intact. There was not a lot of redness on the volar or on the pulp side of the thumb, and the rest of his fingers and hand exam were essentially normal. So this patient was diagnosed with a paronychia, which we'll talk about. Essentially, it's inflammation of the fingers underneath one or more of the three nail folds. And typically it's acute, less than 6 weeks, and caused by an infectious etiology, which is what we're going to talk about. There are chronic manifestations of paronychias, which are defined as lasting longer than 6 weeks and are often associated with other medications or certain autoimmune conditions. And treatment for the acute ones involves some combination of draining an abscess if present, topical or oral antibiotics, and preventative care, especially for recurrent cases. Let's talk about the anatomy of the nail. They are composed of densely packed dead keratinocytes, and the function essentially is to protect the distal fingertip and allow us to pick up small objects. Obviously, when we were different animals, we walked on all fours, they serve different purposes, but in modern society, that is their function. The nails grow from the nail matrix, and the paronychium is lateral to the nail bed. So I'm going to kind of show you some of this on the right here. So here's the entire nail. The nail proper is called the nail plate. Below that is the nail bed. On the edges are the paronychium. This says perionychium, which includes the edge of the nail and the skin around the nail. So in this picture, the paronychium is not labeled. It says perionychium, which is a subtle distinction. On the proximal aspect, you have the eponychium, which is the kind of the middle nail fold over the nail. And then below that is the matrix. And then the cuticle is part of that growing out here. And the lunula is a thickened layer of skin cells over the proximal aspect of the nail. And then the lateral nail fold here is the perionychium. If you look at it from a lateral view, sort of an illustration of the anatomy, you now see the germinal matrix here sitting next to the nail matrix. And that's just the immature nail growing out. Then you see the cuticle and lunula growing out here, the nail plate. The hypochondrium is the area under the nail that's not attached to the skin. And then you see the epidermis and the distal phalanx and the rest of the finger proper. And so when we're talking about paronychia, we're talking about the paronychium or lateral nail folds right here getting inflamed and infected, or up here at the eponychium as well. It can be one or both. The differential diagnosis of paronychia includes eczema, which is very common, herpetic whitlow, psoriasis, and then less commonly dermatomyositis, granuloma annulare, hematomas from pulse ox, which is interesting. I've never seen that. Hyogenic granuloma, Reiter syndrome, food hypersensitivity, melanoma, pemphigus vulgaris, and other forms of skin cancer. All right, on presentation, again, we're talking about the acute form here. Typically rapid onset of inflammation, pain, swelling, redness, tenderness over a couple of days. Okay, these two pictures would be typical of what a paronychia looks like. You see inflammation on all three paronychial folds, medial, laterally, and then on the eponychia here. You can't tell in this one view if there's a abscess or not, but everything is red, angry, and swollen. And then there's something called, so it only involves one digit, typically if it's infectious. If it's autoimmune or iatrogenic or chronic, it typically involves more fingers. If there's green discoloration, you want to think about Pseudomonas, which is one of the common bacterial causes. And then there's something called the digital pressure test, which is illustrated here. And what you see is this is the abscess right here, right? This is sort of, the skin is blanching and then the abscess under the skin is more evident. And all this person is doing is applying pressure of the finger against the table or jeans or whatever we're looking at. and that's kind of outlining the presence of an abscess, and the rest of the skin doesn't blanch because there's no purulence below it. Okay. The diagnosis is clinical. You do not need any imaging or anything else to prove that this is a paronychia. Okay. Sometimes X-rays are obtained depending on the clinical history. Ultrasound can be used to confirm the presence of an abscess. You really don't need to in this case, although I'm a big ultrasound guy. And then MRI, again, not commonly needed unless you think they have osteomyelitis. Over here, I have a couple of cool pictures. On the left side of this is an ultrasound of the right thumb, or sorry, right great toe or the right hallux. Okay, and this is normal nail here. Then below that is the nail matrix. Okay, and then on the right here is the left great toe. I don't like how these are reversed on the picture, but here you see all these inflammatory changes and swelling here. Okay, this is what a paronychia looks like on ultrasound. This is sort of hypoechoic mixed echogenicity fluid, certainly consistent with inflammation and possibly abscess as well. I don't see a discrete fluid collection here, but that may be one kind of right here. Down here you see MRI. You're in the sagittal plane. Okay, volar side is on the top, dorsal on the bottom. I'm not sure what the reason that this MRI was obtained, but basically what you're looking at is inflammation. I think this is maybe the nail here, but you're looking at inflammation of the soft tissue around the dorsal finger. No discrete fluid collection here either. Okay, hyperintensity or hyperintense signal, but no fluid collection. Cultures are not typically necessary, but common bugs are staph, strep, and Pseudomonas. Treatment in mild cases includes some skin hygiene, right? So warm soaks, usually with topical antibiotics, plus or minus topical steroids. I haven't used those that frequently. And then for more refractory or stubborn cases or recurrent cases, you have some boro solution, acetic acid, both of which have antimicrobial properties. And then in more severe cases, they're going to go on oral antibiotics. A couple examples that provide good staph and strep coverage, as well as MRSA, would be amoxicillin, clavulanic acid, clindamycin, TMP, SMX, etc. If there's an abscess, obviously you need to incise and drain it. And in the foot, there's often an ingrown toenail, which is precipitating the paronychia, so you need to deal with that as well. So often you'll need to cut out the ingrown part of the toenail. So in our patient's case, we did a digital nerve block. This is just an illustration. This is, of course, not the one we did on the patient. And there are many ways to block a nerve digitally, but here's one example where you're getting the interdigital nerves on either side of the phalangeal bones, and then you're getting a dorsal block here as well. But there's, again, more than one way to block a finger. And then an incision and drainage was performed. You can see the 11 blade about to enter the skin here with this little, this is really a subungual abscess, not a paronychia in the true sense, but it's the best picture I could find. So they're about to aspirate this with a single puncture with this scalpel. Topical antibiotics and a bandage were applied. This patient was placed on amoxicillin clavulanic acid for 7 days and did well when followed up with primary care. The 3 key points about paronychia. They are one of the most common hand infections, characterized by inflammation of the lateral and proximal nail folds. The acute version is much more common and typically due to some type of digital trauma followed by inoculation of common skin flora. And digital trauma means like biting your fingernails or putting on a nail polish remover or something very benign sounding. And then treatment involves some combination of topical treatments, topical antibiotics, oral antibiotics, and incision and drainage, with most patients having excellent outcomes.